I have 11:03. Again, this is the SURG Response Subcommittee member, September 18th, 2024. We'll go ahead and get started and see if we have any committee members come in. At this point, we'll go to item number 1 on our agenda, which is call to order and roll call to establish quorum.
Dr. Shayla Holmes. Dr. Terry Kearns.
Present.
Nancy Lindler. Christine Payson.
Present.
Senator Jeff Stone.
Here.
We have 3 out of our 5 members attending.
Okay, so that would be quorum. We'll watch and see if Shayla Holmes jumps in. I believe she was going to be present for the meeting today, but we'll go ahead and get started. The next agenda item is agenda item number 2, which is public comment. Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. If you are dialing in from a telephone, you would dial 669-444-9171. And when prompted, the meeting ID is 868-331-1069. And then you would press *6 so the host could prompt you to unmute. Do we have any public comment? I do not see any hands raised or anyone unmuting.
I don't see any hands raised. I do see call in user 1 is unmuted. I'm not sure if that was intentional. And while we're waiting, I would note that Dr. Holmes has joined the meeting and was likely in the waiting room when we were calling order.
Thank you. Welcome, Dr. Holmes.
And it doesn't appear that call-in user intended to make public comments.
Okay, and I just wanted to add that please do not utilize the chat function unless you're having technical issues, because that content may not be available to everyone from the general public, which is a requirement for our open meeting laws. We'll then move on to agenda item number 3, which is a review and approve minutes from the August 6, 2024 response subcommittee meeting. Do we have any comment from the subcommittee members on those meeting minutes? Hearing none, do we have a motion to approve?
Christine Payson, I'll move to approve.
Thank you. Do we have a second?
Second.
Senator Stone, second. Christine Payson made the motion. All in favor, please say aye.
Aye.
Any opposed, please say nay. Any abstentions? Hearing none, the meeting minutes will be approved as submitted. We will now move on to agenda item number 4, which is an update on the jail medication for opioid use disorder multidisciplinary team. We welcome Bill Teal, who is heading up this project, and thank you for coming back and providing us an update.
Oh, thank you, Dr. Kearns, and hello, everybody. Good morning. Again, my name is Bill Teal. I'm a retired captain from the Las Vegas Metropolitan Police Department. Grateful to be contracting with the Department of Health and Human Services for the state of Nevada and working on this effort. Crystal, will you be advancing my slides?
I can do that. I did just give you control, but if you don't see that on your screen, I'll just go ahead and advance them, or let me know if you see that and you can take over at any time.
Perfect. Thank you very much. And if you could advance to the next there, thank you very much. So from a disclosure standpoint, my work is being funded through the Funds for Resilient Nevada. Again, I report directly to Department of Health and Human Services, in this case, Don Yohe. And as of today, I'm not aware of any financial conflicts of interest with the presentation I have for today. Can you advance the slide, please? And one more time. Thank you. And just to kind of recap as to what was presented on the last time I had the opportunity to meet with you all. I talked about the work that was being done. The interest of last year was to pull me in and help DHHS with research in our small and rural jails as it relates to the opioid use disorder and its impact on jail operations. And so what I did was I was able to step inside of all 23 of our jails. Most all of our jails are actual, jails that hold inmates on a regular basis. There are a few of our jails that are considered temporary holding facilities, and that's in Eureka County, Boulder City, and West Windover City as well. But everybody was gracious with me coming in and presenting a survey that we went over together that gave us a baseline to work off of and move this effort forward. Okay, Crystal, can you move the slide, please? So here's what our main issues were. Taking the research phase into an implementation phase. We're wanting to accomplish, the closing of the gap on implementing a medicated assisted treatment program. That's MAT into our state's small and rural jails. And that's absent of Washoe and Clark counties. They've actually been very progressive, with Washoe actually leading the charge for the state of Nevada in implementing medicated assisted treatment inside of their operations. But we're wanting to do the same thing in all of our participating small and rural jails. Currently, we have 6 facilities that are working with us as a multidisciplinary team and working towards accomplishing this part of the objective. And then also the second half of the mission is to provide an effective continuation of care bridge that we'll talk more about. Can you advance the slide, please? Thank you. And just a reminder as to some of the key takeaways from the research that was conducted last year. I just wanted to highlight a couple of things on this slide. First of all, absent again, Washoe and Clark County, none of our other jails had medicated assisted treatment inside of their facilities. And it was simply due to, number one, a lack of access to resources, whether inside of their operation or within the community. And then number two, one of the biggest challenges is access to pharmacies. And there was only one jail that was using a telehealth option as a part of the work that we've been digging into. We're exploring telehealth options as a means of closing the gap on this particular challenge. Okay, Crystal, can you move forward? Thank you. And again, on just a few takeaways here from the research that was done. The main one talking about the 3 barriers, the common barriers to implementing a medicated assisted treatment program. One was the lack of on-site medical and mental health resources. Number 2, the lack of funding. And then finally, of course, the lack of community resources that are available. These are what we were, really focusing on as the main part of the challenge in finding solutions. The greatest part of the research was that all of our jails wanted to work with the state and participate in an approach that would help them get medicated assisted treatment into their operation. There was one facility that wouldn't commit to saying they wanted to participate because they truly believed that they were temporary holding facilities, so temporary that they would only have inmates in their custody on their site for a matter of minutes, if not a total of just an hour. So we went ahead and just recorded that as them not wanting to participate in this particular effort. Can you advance the slide, please? So from a special population standpoint, all demographics within our adult carceral environments are being considered for this work, with, of course, the focus being on substance use disorder, mainly with opioid use disorder being at the forefront. And then, of course, the co-occurring challenges that are tied into substance use disorder being mental health concerns. There's a little bit of a pivot that's currently happening to where DHHS is having me work with DHCFP, Department of Health and Healthcare Finance and Policy, on the CAA 2023 work, and then the AB 389, the 1115 waiver for youth carceral populations. So I'm working with a team of folks from DHCFP to start to make some progress in this area. Surveys already been pushed out to all of our juvenile facilities, and now we're circling back around, conducting some site visits and ensuring that we're capturing as much information as possible to ensure we're gaining as much knowledge for an analysis standpoint and work towards implementing these two things as quickly as possible. Next slide, please. Thank you. And what's working well from an evidence-based practice standpoint? We're using the sequential intercept model, as I suggested earlier. This has been a fantastic roadmap to where we're capturing all the different intercepts of the judicial process to determine what more can be done within the individual counties that are participating to actually work harder at closing the gaps and mitigating the need for bringing folks into carceral environments if it can be prevented. And then 26% of our 23 jails, as I said, are participating in the multidisciplinary team approach towards implementing a jail medicated opioid use disorder program, and then working towards the community continuation of care model. The intention is to circle back around with all of our facilities slowly but surely. We've had other jails that are wanting to participate. The leadership teams of the sheriff's departments are saying, yes, we'll go ahead and participate. The most recent one being Mineral County, which we have our first meeting scheduled for the middle of October. And then in addition to leadership representation from the sheriff's departments, we have, of course, we have 6 Nevada law enforcement agencies. We have 3 county commissioner groups. Those are from Esmeralda County, Lincoln County, and Story County. And then we have 2 judges, 1 judge from Esmeralda, the other judge from Mesquite. And I'm hoping that I can gain the interest of another judge out of Nye County. And then 11 different, actually it'll be 12, because I saw Morgan Green's going to be presenting today, and that rattled my cage as far as like remembering we have a 12th participating group who's contributing to the project, and that additional one is CASAT with UNR. And then lastly, the sharing with others, gaining advocacy and endorsement, really talking about our story and this work that's being done. That is a collaboration of efforts from a variety of folks. Like I said, we have 12 different groups that are participating in this, but actually sharing the story with different entities like the Health and Reentry Project, or HARP. I'm actually meeting with their representatives in DC next week, just to share more about the continuation of our efforts. And the intentions of all of this is to continue to gain advocacy and endorsement. But the National Academy for State Health Policy, we presented to this group on a couple of different occasions, which has generated good feedback. And then in addition to meeting with HARP representatives next week, I'm also meeting with representation from the Department of Justice, Office of Justice Programs. And then towards the end of October, beginning of November, I was invited to participate in a panel at the Police Training and Community Collaboration, or PTAC. PTAC focuses on intercept 0 and 1 of the sequential intercept model. So that's deflection and diversion. So my area of focus is talking about the work that we're doing in Nevada and tying in the significance of and need to incorporate deflection and diversion efforts in our small and rural communities. And if we can make it work there, we can make it work anywhere in any state throughout the country. And then finally, I was invited to come back to participate in a panel discussion with the National Commission on Correctional Healthcare. Again, my focus is the work that's being done in Nevada, with the focus being small and rural communities, who I think all in all, they haven't been dismissed, but they just haven't been the focus with our need to implement medicated assisted treatment. Please advance the slide. Thanks, Crystal. So this is the sequential intercept model, and I know I'm preaching to the choir, as most, if not all of you, are familiar with this, but just another look at the different intercepts that we're working through with our individual counties, starting with intercept 0 in community services, hoping to mitigate the need for law enforcement engagement, which occurs at intercept 1. But still at intercept 1, the need to try and divert as much as possible with the help of community types of resources. And that's one of our biggest challenges, where they simply just don't exist because of the lack of access within our smaller communities. But still, we're working the process, we're challenging the process and trying to find some viable solutions there. But intercept 2, that's at the time of intake and booking inside of a jail. So for our efforts as it relates to opioid use disorder, that's where the implementation of medicated opioid use disorder programming would begin. And it begins at the time of the screening process. So having our service provider being in alignment with the screening and intake process, so we can capture those that would qualify for medicated assisted treatment at that point of the booking process. And then intercept 3, it's like a continuation of the programs that happen in the jails. In this case, MOUD, the medicated opioid use disorder programming, and the counseling that goes along with it. And then from a reentry standpoint, that's where the bridge to community continuation of care begins. And we work towards those warm handoffs with community resources. If we can capture them within the individual communities, that's fantastic. That is best practice. But we're also looking at virtual and regional options as well. Can you please advance the slide, Kristen? Thank you. And here's what kind of like the model currently looks at, like the green areas of these are our current areas of focus and where we're spending a lot of time doing the work. Of course, we've mentioned jail MOUD compliance and opioid treatment program service provider engagement. Currently, we have the behavioral health group who's going to be providing the services within Esmeralda, Lincoln, and Esmeralda, Lincoln, Lander, and Mesquite jails. And then we're working the process to find funding solutions for Story and Mineral County at the time where those intercepts come into play. And then the enhanced monitoring and reduced offsite transports for overdose or suicide attempts. Unfortunately, suicide attempts, they're the #1 cause of death inside of a jail environment. And then when you have co-occurring challenges that are introduced to include substance use disorder, it increases this risk within jail environments. And then opioid use disorder is the #1 cause of death at the time of release. So the enhanced monitoring, it's, talking about what their current practices are inside of their operations and whether or not we can enhance them with redundancies that have been very progressive over the course of several years with different technology solutions that can make these at-risk populations more risk adverse, as far as like the monitoring aspect of the operation while they're in jail. And then the bridge to community care, we talked about that. We'll talk a little bit more about some of the other solutions that are being introduced here further into the presentation. But also another component is the transfer of medical records. We know many individuals, from a sentencing standpoint, they move on to being transferred to prison to carry out their sentences, and the need for the transfer of medical records. So from a medicated assisted treatment standpoint, that program can continue seamlessly. And then the community check-ins with the community continuation of care bridge leading towards engagement from community providers or telehealth or regional providers. It's continuing that level of care, as well as we're working on the introduction of a reentry coalition. And this is being worked on in Landry County. The undersheriff was interested in seeing how this coalition could help strengthen discharge planning and reentry efforts. And then my hope is to circle back around with the Department of Health and Human Services and have discussions that once we were able to demonstrate the proof of concept, that we can make it a statewide effort. But we're going, as we move forward into the model, we're going to look at our outcome reporting needs to really analyze what's working and what's not, as well as be able to dig into whether or not the efforts are truly demonstrating a reduction in recidivism and a break in their cycles of substance use disorder. And I know that something that's at the forefront of the state's interest in developing is an electronic health record that will tie into Medicaid. So with the 1115 waiver for both the adult and the juvenile populations, this will be significant with some of the access to care needs that these operations currently are missing. This will allow for a pay source to actually allow these operations to then bring in the necessary access to care resources. Please advance slide. Thanks, Crystal. And here's what success would look like. I just wanted to highlight a couple that we're currently working on. You know, we're working with the different leadership teams in the participating sheriff's offices, but we'll follow with medicated opioid use disorder education for their staff, as well as, you know, there would be an education for the participating inmates who qualify for MAT, as well as, you know, to help, you know, remove stigmas so we can gain, you know, greater progress. And then I'm hoping that with that educational aspect of the program, that we'll then be able to demonstrate the validation there and gain greater interest in the current non-participating sheriff's offices. And then the community continuation of care piece, you know, you can't say enough about how significant that is, where you have discharge planning efforts in place, as well as the engagement from social services if they existed in the individual counties. But when they don't exist, peer support and the community health workers are tremendous. And I know I shared this with Dr. Kearns in a different meeting, but to her credit and the credit of others, third-party resources, the Nye County Coalition, NAMI, Freedom Bridges, they're all pushing for greater expansion for peer support and community health workers, because the validation of their efforts are proving to even work, you know, in the state of Nevada. So we're hoping to continue to lean in there. We will. We're not hoping, we will continue to lean into that. But more to come as far as what success will look like as we actually uplift MAT. Lander County will probably be our first jail that we get it lifted in sometime next month. And if we can, next slide. Thank you, ma'am. So we've discussed this already, but here's what it looks like. You know, with the implementation phase, we currently have Esmeralda, Lander, Lincoln, Mesquite, Mineral, and Story County participating. And then with the community continuation of care aspect of the program, we're working through this with Esmeralda, Lander, and Mesquite. And then we'll be doing the same with the other facilities once we reach that stage of the sequential intercept model. Next slide, please. And thanks for taking, I appreciate you taking the animation out of here. I didn't want you to have to advance to each different icon, but here's what it looks like in its totality, as far as like all the different groups that are participating in this effort, with the exception of, and I apologize, Morgan, that Casat's not mentioned on here, but they're equally important as everybody else on this page. But just to point out a few, Department of Health and Human Services, of course, they're the overseers of this, and in conjunction with the Division of Public and Behavioral Health, Welfare and Supportive Services, they're currently working on looking at a virtual Medicaid enrollment process that we can implement as a part of the reentry transition. And then NAMI, Western Nevada Executive Director Laura Yanez has probably been the most active in all of our meetings with all the different counties, her and her team. And they've developed the Freedom Bridges that is working towards the discharge planning efforts with all the network of providers that they've developed. Regional Behavioral Health Coordinators, Cheryl Marwood, Mark Funkhauser, Valerie Cowhape. I can't say enough about their engagement and level of influence, as well as access to a variety of different things to help us, you know, bridge several different gaps in finding success here. And then the Nevada Association of Counties, Dr. Amy Hines Sutherland, she's been phenomenal with her support and endorsement for what it is we're doing. as well as helping provide some leadership along the way. As I mentioned at the Nye County Communities Coalition, they've been actively involved for both Nye, Lincoln, and they're participating also in Mineral and Story counties, along with Community Chest. Eric Schoen has been fantastic. He actually was there with me when I presented to the county commissioners in Story County. And then the behavioral health group, they've been identified as the service provider that will be implementing medicated assisted treatment inside of Esmeralda, Lander, as well as Mesquite and Lincoln County. And then we're hopeful that once we're able to get a little bit of time underneath our belt, we'll gain a better perspective as far as what costs would look like from a per inmate standpoint. So with the other counties, we can be able to hone more into funding sources and determining where the access to the funding will come from in order to implement MAT and the other jails throughout the state. PullPack, for those that maybe aren't aware, they're a risk management company who works with most of our small and rural jails on policies, as well as implementing different training on the hot topics to include opioid use disorder inside of our jails. They're helping establish some crisis intervention training access options, along with CASAT, who's not mentioned here, but CASAT also is looking at helping bridge that gap and getting some crisis intervention training options towards our other jails. And then lastly, the acceleration group, they're working as a third party to help implement some technology solutions, which Crystal, if you advance the next slide, it'll be coming up here shortly. But just to kind of recap, the trailblazing efforts here that all those different resources are participating in: statewide MAP medications, the pharmacy voucher process. She wasn't mentioned before, but Dr. Beth Slamowitz with the state's pharmacy commission, she is actively working on developing a voucher process to make this seamless in the future. And then there's different technology solutions that we're looking at for the at-risk signs of life monitoring that will act as a redundancy for those facilities that are lacking resources. And then the community connections to resources, that's going to be on an upcoming slide. We'll show what that kiosk looks like. And then there's some real-time biometrics. There's another company that's very interested in this effort that Silver Summit wants to endorse. They're actually an opioid aid biometric reading device, which is incredible. It's like next level advanced technology. And then we're looking at the access to the community management information system consideration. This is something that's already been implemented in the Clark County Detention Center, and looking to have the same access in our small rural jails. Sober living accountability, the acceleration group, they're participating in a task force currently with the Las Vegas Metropolitan Police Department to hold our sober living environments more accountable. And they're looking to broaden that out throughout the state. So there's just greater accountability, and the expectations are being upheld. So those populations are staying safe, and we're breaking those cycles. But we already talked about the increase in community health workers and peer support. We talked about virtual Medicaid enrollment, as well as a reentry coalition. And just a few slides to show what this MOBEX community kiosk looks like. It's basically a service that's being implemented in our participating county jails. It's being funded through Silver Summit, where the individual counties who are participating, they got to weigh in with the company to explain what they feel were the greatest access needs to resources for their communities. And if you continue to advance the slide. Thank you. This is kind of what the main screen looks like in this case for Esmeralda. These are the different access points that they wanted their community to be able to have. And it's customizable for each of the different counties. So this is kind of like very progressive. It's already been implemented in Henderson, Nevada. And we're looking to expand it again here with Esmeralda, but also with Lincoln, Lander, and Story County, I believe, is also a part of the mix for this technology. Please advance slide. Thank you. And this is just, again, another page that is on the kiosk. So in this case, it's for Employee Nevada, where they could be able to access different employment opportunities. They can scan a QR code and actually walk away with the information on their phone. So very progressive. It just helps link them to resource needs that they may have that will continue to close the gap with that sequential intercept model. The community management information system, I think I mentioned this before, it's already been implemented in the Clark County Detention Center. Information access is something that's been lacking for most law enforcement agencies, especially small and rural, where it can be a true difference maker for individuals who are suffering from substance use disorder or mental health, whether they're inside of a jail environment or even in the field when it comes to someone in crisis. But we're starting to dig into this and find out the how we can incorporate it into other facilities throughout the state. But there's more to come with this as we gain some ground in this area. And please advance the slide. Thanks, Crystal. And then after we actually have the behavioral health group, the MOUD program up and running for a period of time with the community continuation and care bridge, this is what we're hoping to accomplish from an analysis standpoint moving forward. So a lot of it is basically outcome reporting, with both risk mitigation efforts for inside of the facility, but of course, the number one priority here is breaking cycles and saving lives and getting individuals with opioid use disorder access to the care needs, and then being able to speak to it in the future. Next slide, please. So here are the gaps that we currently have. Deflection and diversion gap. One of the biggest ones is the lack of transportation for individuals in crisis. Currently, the practice is that there's a call for service with someone in crisis in the community. You have police who are responding, and now they're having to work the situation with the individual. With a lot of our environments, thanks to NAMI and Executive Director Laura Yanez, they've been able to implement the Avail tool, which gives direct access to a virtual mental health professional. And this has demonstrated some success in counties throughout the state. So that has been helpful. But when it comes down to actually having a need to transport an individual to a resource where they can get the care they need, that's where we're falling off. We're reliant on the actual first responders to then transport. In this, we'll take Lincoln County, for example. They would have to transport all the way down to Pahrump or down to Las Vegas, which is, of course, it's several hours worth of a drive, both there and then back. So you're talking about 5 to 6 hours where they're out of service, potentially putting their community at risk where they're already drained on first responder resources. So this is a gap I'm hoping that we can work on. I know Mark Funkhauser, he's working with the developments of some legislative language that can help improve that. So I'm hoping to learn more on that in the very near future. But the expansion of community health workers, I know this is a huge priority of Dr. Kearns. This is continuing to be worked on with Freedom Bridges. And then the access to information, we talked about CMIS. I hope to have more to share there in the very near future. Community resources, we're talking about bridging the gap there with MOBEX. And then the Medicaid enrollment, as I shared, DeWiss is working on a solution here for a virtual enrollment process. And then the reentry accountability, we're working on the development of the reentry coalition, and we'll have more to report on in the future with our efforts in Lander County. Next slide, please. So recommendations for the SURG group is would love to hear feedback on your thoughts on the status of where we're at with jail MOUD and our community continuation of care, and whether or not this is meeting your expectation or expectations, and how jail MOUD and the community continuation of care model can be improved, and then offer some support to close the gaps. As I shared with you, the transportation issue is a big one, and it's a heavy lift for us to be able to solve. But the evaluation of promotion for our community health workers and peer support, as well as consider the CMIS expansion throughout the state, and endorse the expansion of virtual Medicaid enrollment, and then consider statewide reentry coalition. In this case, there's not too much to share, so it's kind of an unfair ask of the SURG committee. So I hope to report out more on what we're developing in Lander County, so you have more to work off of. And I think that's the end of my presentation, so I appreciate your time.
Bill, thank you so much for coming back and updating. I personally would like to thank you for your efforts, because it appears you're being nationally recognized with this program and putting us as a state on the map in terms of being a leader. So thank you for that. I'd like to open it up to any questions or comments from committee members first. Dr. Holmes, please.
Thanks, Terry. Shayla Holmes for the record. I am so excited to see how far this has come from your first presentation to us, and from I think the onset of bringing you on board to work on this project. I'm personally really excited, or beyond grateful, that you've decided to tackle this first from like some super rural areas of Nevada, because I think if you can figure out how to make it work there, we're gonna be able to figure out how to make it work anywhere. I have a couple questions. Have you seen or heard the impact of 48-hour bail reform on the ability to successfully implement or start an MOUD program for individuals coming into the jail that aren't long-term stayers?
That's a phenomenal question. And I think, putting it in the context of bail reform and those folks that aren't staying in the jail for a long period of time is exactly the most challenging aspect of the process. Regardless, and this is where, a big part of my focus still is with our temporary holding facilities, because they fit into this equation. And my response is that regardless as to whether or not they're in the jail for an hour, or for, the average length of stay on a national level is 29 days. So whether it's an hour or 29 days, the same approach needs to be taken with all of our jail operations. And we should be working towards capturing as much information through a screening process. So at the very least, if they're being transferred to another facility who will be responsible for their access to care, we already have information that can be shared. If they're not, if they're just like a walkthrough per se, where they're only in custody for 2 to 3 hours, it's still important to have that information. So from to mitigate their care needs, this, then gives the jail operation, if they're fortunate enough to have on-site medical resources, then in the event, if something were to happen, now they have some critical medical knowledge of the individual that they can work with. So I threw a lot out there. I hope it answered your question to a degree, but know that it's a part of my discussions, that regardless if they're just a temporary stay or longer term, the same approach needs to be taken. Because I'll tell you, just in my conversations with the Department of Justice, it doesn't matter. It doesn't matter, how long they're inside of an operation. They still fall under the care of that law enforcement agency to continue what their care needs would be from the community.
And you totally answered my question to the degree of possible, right? Do you have the average stayer for Nevada or rural counties? I mean, I had 29 days at a national level, but do you know for Nevada what that number is?
Our number is more like in the 5 to 7 day range. It's far less. And the reason behind that is, with our small on rules, the vast majority of crimes that are being committed are low level crimes. So their stays or their initial preliminary hearings are leading to alternatives to incarceration, which drives that average length of stay way down.
Right. So because my understanding to be able to implement a MAP program is that you would have to have your official formal assessment. So I'm guessing like that 1 hour stay or that 2 day stay, we're using the screener to identify if they need that bigger assessment to be able to get their official diagnosis and start on a prescription. Am I understanding that flow right?
You're correct.
Okay. And then that screener, is that an opt-in or an opt-out? Like everybody coming in, you have no choice. You're going to go through the screening process, or from a different perspective, when it comes to HIV testing in the jails, which is not something I've been successful at trying to advocate for, but I think it's important. Totally not related to this, but similar concept is that the way that looks nationally is there's either an opt-in model or an opt-out model where individuals have to sign saying, I don't want to be tested, and I have to opt out of it or else it's going to happen. Or I'm going to opt in and it's an option and I want to go through this process with you in regards to, voluntarily engaging in what these additional services at the jail looks like. Is it being mandated? That's like, I suppose what I'm getting at.
And I can just speak to this from an experience standpoint. Nothing can be mandated per se when it comes to inmates going inside of the jail. The screening process is going to be the same for every intake. So it's an intake screening process. The intention is to gain as much information about the individual that will help the access to care needs for the overseers, whether it's medical or mental health, in this case, substance use as well. But so we're reliant on them to be consenting to the questions that are being asked, as well as consenting to, if they qualify for participation in a MAP program, that they actually demonstrate their consent to want to participate. So it wouldn't be a mandated program for them to fall into, but my communication to, and we're just getting ready to step into this aspect of the program, the educational piece, but the intention for the service provider as well as myself in sending the message is that we don't stop with just the intake questions. If someone is given the appearance that they're suffering from substance use disorder, and at that moment in time, they're not, maybe they're not present enough to answer the questions, we'll call it that, or they're not wanting to participate, that we circle back around with them. Because in doing so, we have another opportunity to save a life. We have another opportunity to mitigate risk and liability. And then we have another opportunity to demonstrate that the program works by getting them involved. So not mandated, but definitely several layers of attempts to get them to want to participate. I will tell you too that most of our participating facilities, their interest is wanting to capture everyone that would qualify for medicated assisted treatment, not just those that have started a program in the community.
I'm so sorry. Just a couple more questions. I realize I am maximizing my time. So just, I guess, more of a point of learning lesson for us when we first started implementing screenings in our Lyon County Jail back when we went through our sequential intercept mapping model in 2014-ish, right? We just started simple with the brief jail mental health screen. And what we learned really over a couple years of attempting to implement that on intake is it came down more to the training and the passion of the jail operators doing that intake. And so I'm anxious to see what your numbers of engagement look like, and then what training and how you're getting the buy-in of those individuals that are actually conducting those screenings. Because a lot of times when we're hiring jail staff, it looks very different than what we look for when we're hiring, like, say, social services staff. And the way those individuals engage with those screenings and engage with those inmates really does make a difference on the level of outcomes from those screenings, level of engagement, and things like that. So I'm super anxious to see how, once you get further into implementation, what you find to be successful and how that looks. so I guess that's just like a point on the community continuum of care side of things. Are you, planning on, or have you considered what is already existing through the several counties that have the forensic assessment services triage teams? Because while we may not have Matt in some of these areas and not on the counties of which you listed where you're implementing this full scope of your pilot program, but some of that continuation of care is happening in other communities via a slightly different process. So I was just wondering if you plan to roll up some of that information into your report or findings, or if you're planning to consider them as you roll out, or what that looks like.
Yeah, thanks, Dr. Holmes, for the question. Love the FAST teams that have been embedded in a lot of our small and rural jails. Unfortunately, from a resource standpoint, it's not an impossibility, but it's a very difficult thing to implement because of the lack of access to resources. So what has been successful is like the Nye County Coalition, Freedom Bridges. They have developed what they call FAST-like implementations. So very comparable to what FAST is already doing. Maybe not as progressive as far as like their criminogenic risk assessments that they're doing, but with the current participating county jails, you figure the screens that the behavioral health group will be implementing, they're not criminogenic in nature from a risk assessment standpoint. However, they're validated screens on a national level. So we're hoping to capture, the quality information with the MAT screening process. But from a community continuation of care piece, we're really working on the development of something that is FAST-like through Freedom Bridges. So that's where the Reentry Coalition will be a big part of this implementation. So not too much granular detail to give right now. Once we start getting the wheels spinning in Lander County, there will be more feedback that I can offer. But to your point, yes, we're looking to try and capture as many metrics as possible so we can provide an analysis and then determine what's working and what we need to continue to tweak in the future.
Awesome. Thank you so much for taking the time to answer all of my questions and engage in this conversation. I am really excited to see how this continues to roll out and the outcomes and how we can, it's interesting that some of the areas of which have these full FAST programs, which are awesome and robust, are lacking on that front end, right? And so I'm anxious to see how that buy-in looks on the front end and how we're able to, better all areas, if even, the ones you're working with needed it from start to finish. But I think the rest of us still need pieces and components. And I'm really anxious to see how your outcomes impact our ability to motivate some of our other local jails to, to do that full spectrum. So thank you so much. And I appreciate it.
Thank you, Dr. Holmes.
Yeah, thank you to both. Any other questions from committee members?
Yes, I have one, if I can. Hi, Bill. It's nice to meet you, sir. And this is my first time hearing your presentation, and I have to say that I'm extremely impressed with what you're doing and what the ultimate goals are. So thank you for your service in this effort.
Thank you, sir.
On your Nevada trailblazing efforts, you talk about statewide MAP medications and pharmacy voucher process. And can you explain to me what the pharmacy voucher process is? And you were talking about you were having some challenges with it. I'd like to know what those are.
Yeah, thank you, Senator, for your question and kind words. So Bess Lamowitz is working on a voucher process, basically that will streamline this effort to where when we actually have a service provider in place, that the pharmacy will be able to bill the state for the medications that are being prescribed to the patient inmates. Currently, what we're going to do is an interim process is the service provider is being contracted with funding that will allow them to prescribe and then pay for those medications. So the state recognizes an opportunity to where we could do a better job of kind of like managing the funding involved with the medications, because it's a big unknown as far as what the true demand will be until we actually start getting some repetitions under our belt. So the voucher process is just something that we're hoping to implement by the summer of next year and make the payment process, invoice payment process for medications just as seamless as possible. And then all the different jails from a MAT standpoint would be using the same method to pay pharmacies.
So I appreciate that. And as you know, in the 2023 session, we passed a bill that will allow pharmacists to treat opioid patients. And unfortunately, there was no payment to the pharmacy for pharmacists for participating in that. So I have a bill that I'm a BDR, I should say, at this point in time, that I'm going to move forward, that is going to allow a pharmacist to actually get paid, if you will, by Medicaid for providing the services for Medicaid patients, including opioid patients. And I'm hoping that maybe through that effort, we can help bridge that gap. If I can help you in any way with that, I'd love to hear your thoughts, maybe offline, but just want to let you know what I'm trying to put out there, that pharmacists are sometimes considered the most overeducated, underutilized healthcare professional. So we're expanding scope, but a lot of places won't use them for that scope because the institutions that they work for aren't getting paid for it. I'm trying to fix that problem. So maybe there's a synergistic way we can work together to accomplish these goals.
Well, thank you for sharing that information, Senator. I'd love to learn more about the BDR that you're developing. And yes, absolutely. Whatever you need from me from a conversation standpoint or to help support this effort, please let me know. I'd love to. What I can commit to is I'll work towards making a connection with you, and then we can have a further conversation.
Forgive my ignorance. Are you up north or are you down south?
Down south, Clark County.
Okay, good. So I live in Henderson, so maybe we can get together and lunch on me. So.
Oh, thank you. I'll take you up on that.
You got it.
The connections. I love it. So, Bill, I just wanted to provide a little feedback. You had asked about the program and the recommendations to this from the SURG, and I think this program is right in a line. I know, and I don't remember. I think it was the last recommendation report we had was about trying to ensure that we have the 3 FDA approved medications for MOUD available for those in carceral facilities. So that's one. And then, as you mentioned, the information with the CHWs and the peers, that we continue to push for equity and looking at pay and their use. And then I also wanted just to highlight, we have a recommendation, which I think you've heard previously, looking at a definition of recidivism. And if that goes through your multidisciplinary teams, may be something that we would reach out to get some input on that from.
Absolutely, Dr. Kearns. Thank you very much.
Yes, thank you. I appreciate, again, your time and coming back and updating us. And we look forward to future updates.
My pleasure. I appreciate having everybody's time.
Thank you.
With that, we'll move on to agenda item number 5, which is a known bill draft request affecting the behavioral health workforce. And we've asked Valerie Haskins, the Rural Regional Behavioral Health Coordinator, to give us some updates on this. Valerie, the floor is yours.
Good afternoon, everyone. Crystal, would it be possible for me to share my slides? And while she's working on that, I just want to let you know I may have to turn off my camera. My internet has been a little spotty, and unfortunately I noticed it was freezing several times during Bill's fantastic presentation. So if my thumbnail goes away, that is why. So let's see, let's get this rolling now. Okay. So in today's presentation, I just wanted to give a general overview of some of the bills that I've been able to know of regarding behavioral health workforce development. So there are always new bills being submitted as many of you are aware, there are kind of rolling deadlines for many of the legislators to submit BDRs. So while we do have the first batch of BDRs that have been submitted in assigned numbers, we don't know necessarily what's coming down the pipe. Also, when you go to Nellis, there's really just kind of an informational tagline associated with the different bills. So I've been able to connect what I know of to be BDRs that affect behavioral health with the bill numbers as best I can, and that's what we wanted to walk through. We're going to start out talking about the different policy board BDRs and how they either directly relate or touch upon behavioral health workforce development. I then wanted to talk about a bill that I know of from Assemblyman Hafen, and then the Joint Interim Standing Committee on Health and Human Services and the Patient Protection Commission. I also wanted to give a quick update on some other activities regarding behavioral health workforce development that are related to legislative work last session, and then we'll go ahead and go over contacts. I did at the end of this presentation include contact information for all of these groups that I'm going to be discussing. So if you have any questions or want clarification on those BDRs, by all means, feel free to reach out to them. I am not going to pretend that I am an expert on everything. But what I can pretend I am an expert on is the bill of my policy board. So the Rural Regional Behavioral Health Policy Board, this has now been assigned as BDR 54-403. The tagline or the title is simply revises provisions relating to behavioral health, which is very nebulous. But what we're doing with this piece of legislation is we will be entering the Nevada Board of Examiners for Social Workers into the Social Work Interstate Compact. If you are not familiar with interstate licensure compacts, what a compact does is it allows anyone who is licensed within one of the compact states to go through the compact and essentially get kind of like an in-kind licensure very quickly to practice in another state. So interstate licensure compacts can be a really fantastic way to streamline the processes of behavioral health and other providers who are coming to Nevada to practice, as well as it's an added incentive for someone who wants to move to Nevada, but maybe they have existing patients or clients in another state that they don't want to lose contact with. It's also a fantastic way to ensure that we have more access to telebehavioral health providers, because if they are licensed again in one of those interstate licensure compact states, they can go ahead and jump into practice in Nevada seamlessly. Other things that we're going to be doing with this bill is we're going to look at revising the language regarding the annual reporting of licensure data from the 4 behavioral health licensing boards that we've been working with. Those 4 boards are the Board of Psychological Examiners, which oversees psychologists, the MFT CPC board, which oversees marriage and family therapists and also clinical professional counselors, the Drug and Alcohol board, which oversees all different types of gambling, substance use, and alcohol addictive disorder type of treatment. And then last but not least, of course, social work. What we saw was last year when we got the licensure data reports from the 4 different boards, they were vastly different. And we had 2 very comprehensive reports and then 2 that met the letter of the law, but not the intent. And they weren't terribly useful. They almost created more questions than answers. So we really want any information that's published from the licensing boards regarding what's happening and what they're doing regarding who they're accepting and who they're not and why, to really make sense and be a little bit more clear. Next up, we have our sister board for Washoe. Their BDR is S-405. The title there is requires a study of mental and behavioral health care parity in Nevada. What we've heard in the last couple of years quite a bit is that there's concern as to whether or not mental health providers are really getting the parity of pay from insurance providers that they're supposed to be getting through previous statute. And so there were some different bill ideas proposed to fix that and like put more protections and add some teeth to existing bills. But instead, what they wanted to do was really kind of dive into it and see what the actual issues are before they go ahead and change legislation again. So this will be a study to explore where Nevada payers, both public and private, are falling short with the payment parity, and how this can be remedied through statutory change. The Northern Board, which serves Clark, or I'm sorry, excuse me, definitely not Clark, Carson City, Douglas County, Churchill, Lyon, and Story counties. They are going to be working on a bill specifically regarding peer recovery support specialists, as well as certified prevention specialists. And so what they've done in kind of the language that they submitted that I was able to read is they're going to be adding an opportunity for transition age youth to work as peer recovery support specialist interns and start working on that licensure. Transition age youth essentially is those 18 to 24, typically in college type of age groups. And so it's transition age because they're transitioning out of high school and being a minor into adulthood and young adulthood. So that will make provisions for them to become interns, and they will have to be supervised by an adult certified peer recovery support specialist supervisor. There is different levels right in there. They also want to create a workforce pool for both peer recovery support specialists as well as certified prevention specialists, just to make sure that we're kind of bolstering some of those career ladders so that they become really meaningful, viable careers instead of, okay, here's something you can do. All right, how's my picture? Am I freezing up too much? We're good? Okay, I'm getting a thumbs up from Crystal. The Southern Board, which serves Lincoln, Esmeralda, Mineral, and the majority of Nye County, is going to be focusing on transportation. So their BDR doesn't touch directly on behavioral health workforce. However, one of the things that they're doing is going to be creating mechanisms for reimbursement of transportation companies for deadhead miles. And those deadhead miles are those where they're returning to their station after providing transportation to persons seeking services. So having that reimbursement for that piece really helps expand the viability and ability of companies to either come to Nevada or develop in Nevada for that non-emergency behavioral health transportation. Again, non-emergency means that they're not bleeding to death. So even if someone is in crisis, it's still considered non-emergency. The Clark Board's BDR, which is BDR 31-433, revises provisions relating to state financial administration. Again, this isn't directly associated with workforce development, but what they're trying to do is streamline the state's processes for federal grant processing, particularly for grants they have previously received, and it's just a continuity over a next grant cycle. And so in the past, what has happened is some of the processes, either because a position was vacant and so something didn't get turned in within the appropriate time window, there were issues where federal funds were coming down to Nevada and those funds could not be accepted and distributed to subgrantees in a timely way, and several programs almost already closed, which would have meant losing providers, them having to seek other work. So this bill will hopefully help remediate all, if not some, of those issues. Fingers crossed. All right, so Assemblyman Hafen sent in this BDR with Senator Titus. BDR 129, it says revises provisions for governing healthcare. What they are going to be doing is, with this BDR, is entering the Board of Examiners for marriage and family therapists and clinical professional counselors into the counseling compact. The counseling compact is an interstate licensure compact just for marriage and family therapy, or I'm sorry, just for clinical professional counselors. Unfortunately, there's nothing available for marriage and family therapists, but at least we get another opportunity for licensure compacts. If you want more information about the counseling compact, the website here is provided here. Also, if we go back up to our bill, you can learn more about the social work compact at swcompact.org. There is also another map there. The social work compact is newer than the counseling compact. However, both compacts do not yet provide that process for sharing licenses. Like, they're still in the process of getting up and running, so they're not completely functional yet. But they're the only compacts available for those licensure types. All right, so Senator Stone, please correct me on anything that I've got wrong here. So we have Joint Interim Standing Committee on Health and Human Services. These are some of the BDRs that seemed pretty obvious of what they were trying to do relating to behavioral health and workforce development there. So BDR 352 revises provisions relating to social work. From what I was able to connect from the work session document, I believe this is the one that would create a social work apprenticeship program within the Board of Examiners for social workers. The next, BDR 40-353, makes revisions to relating to public health health professions. This one appears to be a really big deal. What it would do is it would essentially take a lot of the or all of the healthcare workforce and licensing agencies and boards, create an office of healthcare workforce and licensing within DPBH or DHHS, and then there would be a subset of that office that would be a specific behavioral health licensing board that would consolidate the 4 behavioral health licensing boards that I had mentioned before. So those boards would cease to exist. It would all be within the one piece. And then additionally, the bill would explore other licensing board consolidation over the interim. How am I doing, Senator Stone?
You're doing good. Okay,
thank you. All right, the next one I have here is BDR 354, establishes priority review for certain applicants for licensure behavior of to practice health professions. So this one is really more focused on health in general terms, so obviously physicians as well. The reason why I included this is because psychiatrists are also physicians. And so anything that affects physicians may, unless they're specifically called out as otherwise, may also affect our psychiatry providers as well. So this bill, taking this straight from the language in the work session document, giving priority review status to the application of an applicant for a license or certificate who demonstrates that he or she intends to practice in a historically underserved community. An applicant shall provide proper documentation, including, without limitation, a letter from the employer located in a historically underserved community indicating that the applicant has accepted employment and stating the start date. So this could be super exciting for not only our underserved communities within urban areas, but also potentially for our rural communities as well. And I think this might be the last one from Interim HHS. Creates the Office of Children's Mental and Behavioral Health. So the purpose here is really to create and consolidate a lot of these programs into the Office of Children's Mental Health. I believe this would also be at DHHS, and tie together a lot of these efforts, because there historically has been a lot of silos between different programs if they are in different either departments or subdivisions of departments across the state. This would also come with a pretty decent fiscal note. Definitely not the biggest that we've seen for sure, but definitely something to think about. All right, the Patient Protection Commission had 3 BDRs, being that it is healthcare focused. Of course, all 3 of their BDRs are healthcare related. So the first one I'm going to talk about, oh, do we have a question? Okay, no. All right, so BDR 54-449 is really going to be as close as we have to, like, not necessarily an omnibus bill for interstate licensure compacts, but there are several different licensing boards that would be entered into their respective interstate licensure compacts with that bill. One of them happens to be the nursing compact. And that would really assist with, like, our DNPs and other nursing providers who can either directly care for a person experiencing behavioral health challenges, including MAT treatment and prescribing and monitoring MAT treatment, as well as other psychiatric nursing professions. BDR 38-451 revises provisions relating to the graduate medical education. Again, this is really focused on physicians, but as we already mentioned, psychiatrists are a part of that pool. So we've got establishing a new Medicaid healthcare workforce fund, and it would really focus on eligible graduate medical education programs, indirect medical education programs, providing fellowship and apprenticeship programs, and also loan repayment. So just kind of a longer term solution than what we've seen previously, it sounds like. And last one, BDR 38450 revises provisions relating to Medicaid. I only saw the one that was posted related to Medicaid, and there were several different BDR concepts during that work session that did kind of associate with Medicaid, so I wasn't certain which one that was. So I didn't want to direct there, but keep an eye out for that one as well. All right, so I am happy to report that Be Here Nevada, or Be Here NV, which resulted from the passing of AB 37 during the last legislative session, they're up and running, and they are almost done with their hiring processes and are getting their programs rolling. What this entity is it is the true K-12 through professional practice workforce development pipeline. It is seated within the NSHE system. Dr. Sarah Hunt, who is at the UNLV School of Medicine, is the executive director there. So it's fantastic. My board's very excited with the progress that she's been making. The programs to be included in Be Here NV include not only bolstering and supporting the opportunities for students K-12 to interact with and learn about behavioral health professions, but also assisting undergraduate and graduate students in attaining internships, getting funding, providing scholarships, connecting them with places where they can get that work in, providing and paying for supervision, because oftentimes for clinical supervision that falls on the student or the new graduate to pay for their own supervision, which is unfortunate. I can't remember, thinking back to when I was a new graduate and broke and thinking, wow, that would be basically impossible. And it is a huge hurdle for many folks to overcome in order to receive their licensure. Dr. Hunt is also getting ready to start building out their advisory committee. It is a multidisciplinary committee, much like the membership in SURG, much like in the regional behavioral health policy boards. We may or may not have used that as a model to build the advisory committee membership chairs. So if there's anyone you know that would be a fantastic person to add to that advisory committee, go ahead and let us know and contact Dr. Sarah Hunt. Here is my contact information. My maiden name is Kwape, my married name is Haskin. So Haskin's great, easier to say. Unfortunately, my email is still Kwape, but at least it clears out some of the spam. And then as far as the other pertinent contacts are concerned, these are my counterparts or their board representatives. So for the Northern Board, my counterpart is Sherilyn Rahr-Wood. For Washoe County, we have Dorothy Edwards. For the South, we have Mark Funkhauser. The Clark seat is currently open, but Jamie Ross is the vice chair, and she was heavily involved in the building and submission of the BDR. So if you have any questions about that BDR, she's a great person to contact. From the Patient Protection Commission, I would recommend Joseph Filippi. Interim HHS chair is Senator Fabian Doñate. Also, I have Assemblyman Greg Hafin's contact here. And for Be Here Nevada, Dr. Sarah Hunt. And with that, I would like to open it up for questions.
Thank you so much for that very comprehensive review. Any questions from the committee members? You must have answered all their questions already. So thank you again. We really appreciate this. It's obviously of special interest to us here with the work we're doing. So hearing no questions, we'll move on to the next presentation, which is agenda item number 6, an update from the Nevada Opioid Center for Excellence. And we have Morgan Green. I also saw that Michelle Berry's on the call, so I'm not sure if it's going to be Morgan or Michelle.
It's me. Thanks, guys. Michelle's just here to listen. I will try to keep this short because I know we're coming up on time, but I just kind of wanted to provide some information as to what the activities have been for the OTAC that we have been working on. Thanks, Crystal. So this is fully funded by the Fund for Resilient Nevada. That's really where most of this activity is coming out of. Worked. Okay. So
I'll stop and you can carry on.
okay.
I think you have the ability.
I got it. All right. So the OTAC really has dedicated in developing sharing experience. Really, what this program is to provide training for both individuals that are in the professional fields in behavioral health, as well as providing much needed information to our community members, because we want the people on the ground to have some awareness as to resources that exist and some things that they can take some control in as well. So this is really to provide access to information and resources to all members of our Nevada community. Right. So between April, when this launched, through August, we've received 23 different technical assistance requests. Currently, 6 of those requests have been closed with the resources provided that they were missing. 5 have been closed due to providing the in-person or on-demand training. Much of that was in person. 9 have been closed due to unresponsiveness to follow-up attempts. So just to be completely open, we do follow up with everybody who puts in a TA request. We don't always hear back from them, but we want to be cognizant and just be very open about the fact that that is happening. And then we have 3 current outstanding technical assistance requests that we're still currently in the process of meeting. In addition to those, we also provide live virtual trainings. These live virtual trainings do include the opportunities to receive continuing education. Once they are completed, they go into the on-demand library where people can have access to them at any point in time. They just no longer have the attachment of that continuing education anymore. So there is an incentive to attend these live. And as you can see, from what has been completed, it's been pretty good turnout. So for the first listening session, we did just have the second listening session. There were 93 live attendees. For the drug-induced homicide laws and Good Samaritan that we did in conjunction with the Attorney General's office, there were 91 live attendees. We've heard nothing but good things and reported back to us about that one. And then just kind of looking at those numbers. In addition to the live trainings, we do have some trainings that have been developed that are only on demand. We didn't do them live so that these do exist for ongoing access. Most of these are around a lot of our more common or basic trainings that we can provide, including overdose education for specific populations such as law enforcement, community members, as well as within provided in Spanish so that we do not miss that population as well. We've also worked with Wisebatch, who is our primary provider of the test strips. They are the same, they're one of the branch offs of the most common test strips that Southern Nevada Health uses as well. But these also include the specific instructions on the back of them. So we worked with them to provide specific trainings that people can access that have some specializations, such as for individuals who are primarily intravenous users, for those who are testing amphetamines and MDMA, as well as those who are testing pills. They can look at their specific needs to see how those work. And then we do have several upcoming trainings. We just had the harm reduction listening session yesterday. We had over 100 people attend live, and we have, in conjunction with these listening sessions, we are producing a podcast, which has follow-up content with the panelists of each one of these listening sessions, so they can provide a bit more information based on some of the information they received back during that session, so that hopefully they can answer some extra questions for people. We also have an upcoming overview of opioid use, recent trends, emerging substances, and strategies for providers. We do know that xylazine has really started to make its way into the state. We knew that this was coming. We just want to provide more information around that, as well as some of the other trends, including the addition of nitazines that are being found in the supply as well. So we want to give people a heads up before they fully get here so people are prepared. And we are also producing a medications for opioid use disorder, just the basics, really with an emphasis for the rural communities. We want to really, again, try to provide that low level information to start that conversation, getting it going. So then we can hopefully provide better and more personalized technical assistance as different agencies become interested in adding that into their already fulfilled pieces. There we go. Some other programs that are in the works but not yet scheduled. So these are what we are planning on producing. We haven't set a date for them yet. We have an introduction to ACEs that we want to develop. We also have Basics of Nevada Plan of Care. We know that there's amongst the professionals, there's knowledge of this, but we want the community to be able to have access to that information as well. Understanding the open bed system, and then integrating family-centered care. A lot of these are based on that Nevada state plan. So we want to ensure that we are meeting those qualifications that have been identified as targeted areas. And then extra activities. So again, just kind of bringing it back to that podcast. The first podcast has actually been launched this week. It's on Spotify. We're working on getting it on the other pieces, but currently you can access the Nose Dose on Spotify. In addition, this isn't specific to NOS, but I know that there's been a lot of conversation around it, so I want to bring it up. For university campus distribution of naloxone, there's a lot of questions around NCHI. So I want to give UNLV a shout out first and foremost. They've been distributing for over a year. They work specifically with Southern Nevada Health District. I don't think they get enough credit for that. But the University of Nevada, Reno also launched their campus distribution this semester. Just as a note, we had over 1,000 students already attend. All right, can you guys still hear me? Okay. So we had over 1,000 students already attend the live webinar, or the recorded training for students. Once they attend that training, they have the ability to get a certificate to go and acquire naloxone at certain distribution points. It's all through their web campus. And so in 3 weeks, we had 1,100 students. I think that's probably a great sign. TMCC is going to adopt a similar avenue for distribution. So they are going to also pull that over onto their own web campus to be able to start launching that distribution. So we are seeing that this is growing. So I just want to say that it's been a target, I know, for a long time. And so it is growing. And I think we've found an easy way to get that implemented that schools are comfortable with. All right, so that's what I have. Do you guys have any questions?
Wow, that's what I have to say. Great work that you guys are doing. I know I've attended a few of the
Oh, hold up.
presentations, and
The
they've been
headphones
very...
are off again.
Can you hear me?
Okay, I think I got it fixed.
I was just saying great work. Are there any questions from committee members? Can you hear me? Okay.
I can hear you, Dr. Kearns. I don't have any questions for Ms. Morgan Green, but I do love the trainings, and it's really exciting to hear about the distribution on campuses, because I know that's been a concern and a question and things that have come up during our SURG conversation. So it's awesome to hear it's happening.
Yeah, great work. I did have one question. I know you said there were 91 attendees who attended the Good Samaritan drug overdose and drug-induced homicide law presentation and training, and the feedback was good. But do you have what the breakdown was? Was it law enforcement? Was it members of the public? Was it a combination? And was there any specific feedback, good or bad, that you want to highlight?
You know what? That's a great question. We did collect all of that information. I'd be happy to send that along. I don't have it on me in front of me at the moment, but I can absolutely send all that information so that you can see the demographics of who attended, as well as any of the feedback that we received. Because we do have, at the end of these trainings, a survey that people are asked to complete so that we can kind of address and tailor things. I think, to be honest, one of everybody's favorite things was the length of this training. I think they all absolutely love the fact it was 30 minutes. Short and sweet, and got all the information they wanted. So I'll let you know exactly what those other pieces came in as.
No, I appreciate that, because that's a recommendation we're still trying to refine and decide how we're going to process forward with that. So thank you. Hearing no other questions, we'll move on to our next agenda item, which is finalizing our preliminary recommendations. And I'll just highlight that the subcommittee, we need to determine if we'll move each recommendation forward as a 2024 recommendation, and if moving forward, determine if there are revisions to be made to those the recommendation language or corresponding components. And what you'll see in the upcoming slides is the items in red are indicate a suggested change or new information collected by staff from the subcommittee members and subject matter experts for the subcommittee's consideration. And we would refer you to the SURG response subcommittee recommendation submission September 2024 handout for additional information that addresses things such as urgency, advancement of racial equity, and capacity for each of the recommendations. The first recommendation is basically, we had previously recommended a BDR to have a statewide definition of recidivism, but after some feedback that we have gotten, revised this to what you see on the slide here to recommend state agencies under the legislative, judicial, and executive branches involved with deflection and diversion programs have a comprehensive definition of recidivism and policies related to measuring and reporting recidivism. And really the action item on this is to suggest policy to those state agencies. And a few of them are listed here: Department of Health and Human Services, Department of Administration, Department of Corrections, which right now does have a definition of recidivism, and the court systems for having that comprehensive definition of recidivism, and policies related to measuring and reporting recidivism. It's often broadly defined as reoffending. However, we need more specificity for understanding and measuring recidivism rates. And I know personally this has become an issue because we, through grant funding, do fund some of the most and fast teams, and we often are using different definitions, so it's hard to compare those against each other. It's kind of comparing apples to oranges instead of apples to apples. So that was why we came up with this recommendation, basically coming from Cheryl Woods from the Northern Regional Behavioral Health, who has been spearheading a lot of the activities of FAST and MOST. So I open it up to the committee members. Any questions or comments on this recommendation? Oh, I should move to the next slide first and just say we did receive feedback from out of the Nevada Sheriffs and Chiefs, from Elko Police Chief Taylor Troughton, that rather than just look at arrests, we should also look at arrests rather than just convictions to be part of that criteria, because then someone who entered a plea wouldn't be accounted for. And he recommended that 3 years would be too short a time period, as felony offenders are often not convicted within that time frame. So that was some of the feedback that we received. So any discussion or thoughts on this? And I would just suggest for a time, rather than looking at each of the individual, maybe we will vote on all of them together. No comments or feedback on the first one. We'll move to the, we can move to the next recommendation. Recommendation number 2 is, this has to do with the statewide data sharing agreements with the chief data officer of our state, and implementation of a cross-sector database housing multiple points of data access across prevention, treatment, recovery, and criminal justice. And this would include data such as controlled substance outlets, tobacco, cannabis, and alcohol, to help tailor interventions geographically. And this was some of the feedback we had gotten from a recommendation from, I believe, the Prevention Subcommittee. Dr. Holmes, if you'd like to add anything.
No, you pretty much nailed it. We had the presentation from the state of Virginia that has successfully implemented a data based structure such as this, with the very clearly defined data sharing MOUs. And I think that incorporating the Prevention Subcommittee's recommendation only strengthens it. And that's all I got.
Any other comments or questions from committee members? Okay, hearing none, we'll move on to the next recommendation, which is recommendation number 3, support the collaborative proposal to the Fund for Resilient Nevada to conduct sampling of high schools, college, university campuses, and bars and nightclubs, and use information gained to develop public health awareness programs, deploy targeted naloxone, increase provision of fentanyl test strips to targeted locations, and to develop a plan for expanding high-risk substance wastewater surveillance in Nevada, and review the outcomes from this pilot program to identify if it and similar targeted programs may aid in the community response. And if you look under the justification, use cases specific to Nevada were provided at our August 6, 2024 response subcommittee meeting. And I would also like to highlight that with this recommendation, we received feedback from Dr. O and Dr. Garrity that their proposal to the Fund for Resilient Nevada was recommended for funding. So they'll be updating their budget to meet fiscal year requirements, and they hope to continue to connect with the SURG to determine how to use the data to make a significant impact. So anything else you'd like to add, Dr. Holmes?
I'm super excited to hear that they were funded. Just a reminder that this was a recommendation from last go around that did not receive the votes, I think, to be ranked. But the goal of that recommendation was to determine the cost, because I think the data is absolutely along the lines of which we are looking for to meet our legislative requirements on how we can be data driven and making decisions and being able to respond to a variety of different substances. But the cost was really unknown. So I'm super excited that this proposal has been funded and that it is a small target population. And so that way, I think, you know, we're going to get a lot of the information that we were seeking to find from our initial recommendation from this one. That's it.
And I would highlight too that in the research that we did find there are other states who have implemented this and been using it as a way for the looking at surveillance from wastewater for drugs, and have successfully implemented. So, okay, we'll move on to the next recommendation, which has to do with my question that I had for Morgan Green. Recommendation 4 is again one that we had previously had, and it's to resolve the conflict between the Good Samaritan Drug Overdose Act and drug-induced homicide law. Immediate actions may include recommending community-level education using best practice guidelines, as well as education for law enforcement personnel, which, as you heard, has already started. And then a recommendation from our committee was to explore options for altering the Good Samaritan language to expand coverage to a greater population of individuals living with substance use disorder. Any comments or questions from the committee on this one? I would just highlight that the addition of the part in red is because through testimony that we've heard to various committees and the legislature is that there are individuals who still do not feel comfortable calling 911 when they have witnessed someone experience an overdose. And as we know, even though bystanders may administer naloxone, the best practice is still that they should receive follow-up care. So, so that was why we looked at adding that language. Okay, hearing no questions or comments. Our next recommendation, action item for this one is the subcommittee would continue to research and track this. And that what takes us to our next recommendation, which was submitted by Senator Stone. It's to implement a voluntary program to install drug take-back bins in retail pharmacies. Senator Stone, would you like to add anything to this recommendation?
Yes, thank you, Chair. When I was a California state senator a few years back, we needed to find a place for people to dispose of their pharmaceuticals instead of flushing them down the toilet and tainting our water supplies. But as we've seen the opioid crisis get worse and worse, what we're finding is that people that have opioids that they're not using, elderly people, are keeping them in their medicine cabinets. People are stealing them. I'm sure you've heard of the skiddling problem, where kids are taking drugs out of their parents' or grandparents' medicine cabinets and putting them in a bowl, and based on the color, they're taking the pills to see what kind of effect they can have, which is in many cases is deadly. So the easy thing about California was it was required that we put them all in all pharmacies, and we had a division of toxic substances that went around each respective pharmacy monthly and got rid of the contraband, if you will. Unfortunately, Nevada doesn't have a division of toxic substances that can take on this role. So I had a bill in the Nevada legislature in 2023 that would make this a voluntary program. And I discovered that there are a few pharmacies in specific geographical areas that have these bins. A lot of sheriff departments or police departments also have them, but it's kind of intimidating for people that have medications, whether they're legal or illicit, to take them into a drug disposal bin in a police office. So basically, what I'm trying to do in Nevada is make a voluntary program for pharmacies to put in these bins and to have a funding mechanism to pick up the waste and incinerate it, and try to keep the marketability, if you will, of controlled substances from being diverted back into the market. As an example, you can get a Percocet or Percodan pill on the street for $20 to $30, $40 a pill. I want to try to reduce that diversion of narcotics and other controlled substances, and ultimately clean our water supply up as well by having these take-back bins. And so the reason why it was killed in the last session was because the chain stores felt that it would be voluntary, but that the legislature would come back and make it mandatory and basically create an unfunded mandate, which was never the intent of the legislation. So I would like to submit another BDR this year to again talk about it. It's a voluntary program, and if there's a way that we can use funding from the opioid settlement to pay for the collection and incineration of these drugs, I think it has a much higher propensity of being acceptable in passing.
Thank you for that additional information. And I would add, I know some of the prevention coalitions who do the drug take-back days and have done those in collaboration with law enforcement. I believe in the last notice of funding opportunity from the Fund for Resilient Nevada, some of the prevention coalitions also submitted some to have drug take-back bins, not in pharmacies, but located throughout the communities. So there's a chance probably for some collaboration. I think one of the coalitions also asked to get funding for incinerator. So previously through the AG's office, there were 4 incinerators placed at law enforcement just for this reason, to help with the incineration of some of the drug from the drug take-back days. So any other comments or questions from the committee?
One more thing I'll add is that the bill was passed in California, and as a result, there's been a dramatic decrease in the contraband that's come from medicine cabinets and reducing street drugs that were once legal sitting in people's medicine cabinet. I actually won the Environmental Quality Award in the state of California for this bill. So it was very successful, and I think it could be modeled here in Nevada and be very successful as well.
Congratulations. That's great news.
Thank you.
No comments, hearing no comments or questions from the committee. We'll move on to the next recommendation. And this is just an additional recommendation for consideration that was revised from the 2022 annual report and removed from the 2023 annual report ranking. But it's something we may want to consider, and it's the review, the operations and lessons learned from Clark County's Overdose Fatality Review Task Force when that body's report is released in December of 2024, and take this into account when supporting legislation to establish regional overdose fatality review committees, allowing flexibility as to the makeup and practice, and for the OFR to remain at the county or regional level as needed to effectively identify system gaps and innovative community-specific overdose prevention and intervention strategies in accordance with established best practices, such as BJA's Overdose Fatality Review Practitioner's Guide. We will be having a presentation from the Clark County over the Clark County's opioid task force upcoming, so we'll get more information. But I just bring this up is that we may want to consider this recommendation again based on what we hear from Clark County. So it may be a recommendation moving forward. So at this point, do we have any conversation on those recommendations, or do I hear a motion to move the recommendations forward?
This is Shayla Holmes. I'd make the recommendation to move the motion to move the recommendations forward as presented.
Second.
Okay, so we have Shayla Holmes with the motion and Senator Stone with the second. So we will get those prepared to move them forward for our next SURG meeting, which, moving on to the next slide.
I think Chair Kearns, if you just would take a vote.
You're right. Thank you for keeping me in line. All those in favor of moving the recommendations say aye.
Aye.
Aye. Any opposed, say nay. Any abstentions? So we have unanimous of the members present to move those recommendations forward. And we'll move on now for item number 8, agenda item number 8, presentation of response subcommittee recommendations for our October 9th, 2024 SURG meeting. Chair Holmes, so Vice Chair Holmes.
All right, on October 9th, we'll be having our full SURG committee meeting. This has been a standing agenda item for the last several meetings, and this is our opportunity as a subcommittee to give recommendations on what we would like to be reported out. Dr. Kearns, as our chair, typically presents for us to the full SURG our current recommendations and is present to answer any questions. And then those of us with recommendations or any other thought process on the recommendations, whether it's yours or not, are able to provide comment and feedback at that time as well. Is there anything that the committee right now would like to make sure is on Dr. Kearns's radar for her report out on October 9th in representation of us all? All right, so if you guys can note that our subcommittee, our response subcommittee, will be meeting again on November 5th. So this is your last opportunity to provide any direct feedback as far as what you would like to be reported out on that October 9th. And then we will meet again on November 5th, at which point we will be finalizing our recommendations based off of feedback from the full SURG in October.
Just one item that I would highlight along the lines for the October 9th full SURG committee member is AG Ford will be looking to the SURG members as to how we're going to move the recommendations forward, as we've previously talked about in our subcommittee meeting, and that would be whether we're going to use what we used in 2022, whether we're going to use the process we used in 2023, whether we're going to, and that was basically having all of the subcommittees ranked, or all of the subcommittee recommendations ranked against each other and then rate it, or not include it in the recommendations that were rated. And the other options are to have the recommendations by topic area. So that would be prevention, harm reduction, treatment and recovery, and then response, and rate them within each of those topic areas. Or the last one is to have them in the topic areas and not rate them at all, but include them. And I would highlight that in the past, we had a lot more recommendations than what I believe we'll have this year. I know one of the other subcommittees talked about carrying forward fewer recommendations. And when I say that, it was 20 or more recommendations that we'd had previously. So we will likely have fewer. So be prepared for that conversation at the October 9th full SURG meeting, and how you want to vote on that.
Thanks for that update, Dr. Kearns. I'm looking forward to that conversation very much so.
Okay, moving on to the next item, which is agenda item number 9, upcoming response subcommittee meeting. Vice Chair Holmes.
Well, our next subcommittee meeting is in November, as we just stated, 11 o'clock to 12:30. I don't think we have any other dates at this point in time, except for the full SURG coming back again in January. Right now, it looks like it's tentatively being scheduled for January 13th from 1 to 3. And I believe at that meeting is when we will be finalizing the SURG report based off of the work we do in October and November.
Thank you, Chair Holmes. This is Crystal Duarte for the record. I just wanted to note for committee members that if you can please accept or decline our future meetings, that helps us understand if we'll have quorum or if we need to lean on other members to attend. And that November 5th date is election day. So get out and vote early and then join us for our meeting, because we do plan to go forward on that date.
And vote early just to avoid the lines. And the meeting is also important. But I believe that's it. I don't think there's any, I believe we'll figure out future meeting dates after November based off of regrouping. Are we going to be, maybe this is like a not appropriate question, Crystal, are we going to be figuring out subcommittees again post the January report? Is that why we're sort of in this hold pattern with our subcommittee?
I do believe that, yes, every year members have the opportunity to select a committee that they'd like to be on, or they could remain on a committee. And I think we do that. Can't remember if we do that in December or January.
Well, that is why we haven't figured out a meeting date. But hopefully you all stay on the response subcommittee. I greatly appreciate working with all of you and all of the progress that we've made. And so I would love to see us keep our momentum going. Not to say that that can't be awesome with fresh blood as well.
And one thing I would just like to highlight before we go to the next agenda item is that thank you all for the work that you have put in, because your recommendations do make a difference. As you've heard, people do take them into account. For example, some of the training that's been provided through NOCI, and then also the regional behavioral health policy boards have listened to the recommendations and have taken some of those on as well. So your work is important, and it does make a difference. So,
and to that note, Dr. Kearns, I don't know if you saw the recent notice of funding opportunity for the SOAR funds from the state, but they put in the NOFO anything from the SURG recommendations is being prioritized for funding through that grant opportunity, which I thought was super cool.
Yeah, thank you for highlighting that. I didn't realize that. So, Excellent work, all. We'll move on to the next agenda item, which is agenda item number 10 for public comment. Everything being as it was in the first public comment, we will open it to see if anyone has any public comment. I don't see any hands raised or anyone coming off mute. Crystal, do you see anything?
I don't see anything either.
Okay, great. At the next committee meeting, as you all know, if there's recommendations, as we've done previously, where we may have to potentially combine recommendations from another subcommittee if they're similar. So that would be some of the work we would have to do and just refine our recommendations as well. At this point, we will move on to agenda item number 11, which is adjournment. And I'll give you back 6 minutes of your time, seeing how I went over the last meeting. So thank you all.
Thank you.
Bye, everybody.